Hello doctors, welcome back to Jabstudiesmetfun for Diabetes Mellitus Part 2. In this part, we're going to talk about multiple things, which is like normal glucose versus how insulin maintains our blood glucose, what are the types of routes through which we give insulin, what are the drugs used in diabetes, and much more. All of them are very important with respect to your examination, and also it is very important for your clinical practice as well. So I hope you understand this topic. It is a very understanding topic rather than mugging up of topic. So without further ado, let's start this session. So first thing what we need to know is what is our normal glucose peak. So basically what happens is I have a graph over here which shows the representation of a normal person who does not have diabetes or sugar. So basically what happens is that if you see the normal baseline comparatively is low, which is with respect to the previous video we talked about, if the RBS is between less than 140, right? So they will have a lower baseline. But if you talk it with respect to a person who is having uncontrolled sugar. Now the reason of uncontrolled sugar is either if it is type 1 diabetes, then there is no insulin at all, or type 2 diabetes in which there is insulin resistance. Because of insulin resistance, the patient will be suffering from a high baseline level. Second thing is that whenever you notice one thing, that whenever you eat something, for example, your major meals like breakfast, lunch and dinner, there will be a sudden spike of glucose. There will be a peak over here, but this peak is it's brought down by what? It is brought down by insulin. But on the other hand, if you notice one thing, a person who does not have proper insulin regulation, the receptors are not functioning, if there is no insulin at all, these peaks are going to be much higher and they are not going to be controlled. So patient already has a very high baseline level of sugar, and along with that, whenever he or she eats anything, the peak levels are very high and there is uncontrolled glucose. So what we have to do? If we talk about type 1 diabetes, in type 1 diabetes, there is no oral hypoglycemic agents, which is OHAs. There is no role of OHA, you have to give insulin. On the other hand, if it is type 2 diabetes, the first thing what you have to do is lifestyle modification. If lifestyle modification does not work, we start with oral hypoglycemic agents. If oral hypoglycemic does not work, the next thing is insulin. So we're going to talk about something with respect to insulin. Okay, so whenever I talk about insulin, let's think about biochemistry. Insulin is a 51 amino acid chain, okay, A and B. Earlier we used to use beef and pork insulin, but because of reactions and resistance, we stopped using it. Along with this, another main reason why we stopped using it is because of the development of human insulin. Okay, it is a combination of DNA. So it's a DNA recombination technique. In this DNA recombination technique, it is a C-type DNA. What type of DNA? It is a C-type DNA. So what are the types of insulin? Insulin can be divided in broad terms in 4 parts. One is the rapid acting or ultra short. Okay, they're also known as ultra short. Ultra short. So the rapid acting of the ultra short example of them are Lispro, Aspart, and Glulisine. The thing in these insulins are their peak action is very fast of onset, which is 20 to 30 minutes and can last for around 3 to 4 hours. In the short acting ones, you have classically regular insulin and you have semi-lent. The important part in short acting one, which is also known as your rapid regular insulin, is that this can be given subcutaneous, which mostly all the insulins is given. But the key thing which you have to remember over here is that the regular insulin is insulin which you can also give IV. So they will ask you which of the following insulin can be given IV. Your answer should be regular insulin. So regular insulin can be given IV. Their peak action is within 2 to 4 hours. So where can you give IV? Now why do you give IV? IV has 100% bioavailability. Why do you give IV? Because you can give so whatever we want, our desired result can be done fast. So in an emergency condition. So which of the following condition will you give regular insulin in an IV route? Conditions like diabetic ketoacidosis, conditions like hyperkalemia, conditions like hyperosmolar coma. These are the conditions where you will give regular insulin with the help of intravenous route. After short acting, you will have the intermediate acting. In intermediate acting, you have 2 types, NPH and Lente, where NPH is neutral protamine hedgehog, and along with that, you'll have Lente. In intermediate, you need to know the duration of action will be much longer. Okay, it is a very long action. It will be around 12 to 18 hours. 12 to 18 hours. And peak takes around 6 to 12 hours, which means it starts slowly, but it lasts longer. Okay. If you talk about long acting ones are basically peakless type. So their examples will be Glargine, which can last up to 24 hours, Detamir, and deglutec. Now the important part of the deglutec is it is the longest acting insulin which can last up to 42 hours. 42 to 48 hours. So many MCQs in this slide itself. The longest acting insulin, deglutec. Which one is given intravenous? You will have regular insulin. Which are the conditions you can give intravenous? Diabetic ketoacidosis, hyperosmolar coma, and hyperkalemia. That is why, remember, when we were talking about diabetic ketoacidosis, before giving insulin, you should always check potassium. If potassium is less than 3.3 milliequivalent, you will not give insulin. Further, the patient will have hypokalemia. Hypokalemia will give muscle paralysis. Person will not be able to breathe and he will die. And remember, please let me know in the comments what is the most common cause of death in diabetic ketoacidosis, because this has been repeatedly asked in the exam as well. Okay, we discussed about this in the previous video. Next, so once we're done with this, let's talk about the basic difference which we talked about. So in ultra short or rapid acting and in short acting, what was the thing you noticed? The peak onset is very fast and the duration is short, correct? The peak action is very fast and the duration is short. On the other hand, the intermediate acting and the long acting, these are the one where the peak is very slow, it starts slowly, but the duration is going to be long. Now, why do you want to know this? See, let's go back to the previous graph over here for a normal cycle. See, the normal baseline level. What is normal baseline? Normal baseline, which means the glucose is maintained throughout the day. So we need a type of insulin in a hyperglycemic patient over here who can maintain this throughout the day. This throughout the day is maintained by either the intermediate one or the long acting insulin. Second, we need something, that insulin, whose effect should be so fast, but it should be done as much as we require. For example, whenever we eat breakfast, now the glucose spike will be there for a particular period. It will not be for a very long time. So we need to control that spike for a short time. That is why we are going to give insulins like the ultra short acting and the short acting insulin for the meal time. I hope you understood. So generally, in a basic way, for the baseline, we are going to use intermediate type or the long acting, and for the meals, we are going to use the short acting and the ultra short acting. Using this regime which I just described, let us talk about the regime which is known as the Basal-bolus regime. Now basal, how I remember this is basal. Basal for baseline. Okay, for basal for baseline means this basal type of insulin is those which maintains the baseline. Whereas bolus, remember when you talk about bolus, it is like sudden. So bolus are the ones which are going to maintain the peaks. The peaks which are coming, the high peaks, we want to control those peaks. So that is the one which will be controlled by the bolus insulin. So let us talk about this example. As I already told you, the baseline in case of your basal-bolus regime is a long-acting insulin. Examples of long-acting insulins are glargine, deglutec, or detemir. These are ones which are known as peakless insulins. They don't have any peak. They will be constant throughout. Thereby, the blood glucose will be maintained normal. Now, for those which are there in case of the meals, what are you going to give? We are going to give an ultra-short acting. Ultra-short acting example, Lispro, Aspart, and glulisine, correct? So what are we going to do is, and how are we going to do this? See, how will you advise the patient? How will you give insulin? First of all, you need to know basal-bolus regime is the best. Why is this regime the best? Because it mimics the actual, it synchronizes the actual insulin. If the patient did not have resistance, or if he had insulin, it would mimic the actual human body mechanism. So we need one, as I told you, one to maintain the baseline, that is responsible by the long-acting insulin. We need another type of insulin which should be given just prior to the meal so that the peak can be controlled. So one, we are going to give the basal, that is long-acting insulin. When are you going to give this? You are going to ask the patient before bedtime, take this. So at night, so before bedtime, okay? When are you going to give the bolus? You are going to give the bolus is, first of all, let's talk about breakfast. What are you going to ask the patient is, prepare the meal, prepare your meal first, okay? Then you do your blood glucose test, okay? Using the glucometer, take a prick and check the blood glucose. After the blood glucose, take your insulin shot. So you checked it, okay? Then you take your insulin shot. And very important, after insulin shot, you have to eat. Okay, many people, what they think is, okay, I'll just take the shot and I'll go. Many people just fall dead because of hypoglycemia, because insulin, what it will do, it will push all the glucose inside. In the blood vessels there will be no glucose, because of which person can suffer. And remember, in diabetes, quick onset of death is because of hypoglycemia, not hyperglycemia. So that is why whenever you give a patient insulin, always ask them to eat. Always ask them to eat. Okay, so what is the method we are going to do? The method is, like, for example, before breakfast or before any meal, we're going to ask them, make sure that your meal is ready. Second, you will check the blood glucose. After checking the blood glucose, you will take the shot. After doing the shot, then you will eat the meal. So this they have to do. Now you notice one thing, how many injections is this person going to take? If there are 3 meals, breakfast, lunch, dinner, 3 times, and the long acting one is before sleeping, so 4 times, and before every meal he has to prick and check the glucose. So basically around 7 times this person is getting pricked, which is painful. So the issue with basal-bolus regime is the best, but the issue with basal-bolus regime is compliance. People will not be able to comply well with it. And second issue is that people tend not to eat properly. That is why even after insulin they eat less, and the chances of hypoglycemia is very high with case of basal-bolus regime. So just remember, advice to the patient will be, the basal one is you have to take it before bed. Bolus will be before every meal. Make sure the meal is ready, check the blood glucose, take the shot and eat. Remember, the basal-bolus is the best. But the disadvantage is there is poor compliance, because around 7 times you're going to prick that patient. Obviously, he's going to be irritated. And the risk is hypoglycemia, because they don't eat properly. Now, how will you give this dose? Very importantly. So what are you going to do is, you will measure it 0.3 to 0.5 international units per kilogram, or units per kilogram. For example, if the patient's weight is 60 kg, okay? What you are going to do is, you are going to divide the 60 kg into 50%, which means the long acting one will be 30 international units, okay? And for the bolus, you will give 30 international units, okay? Now this 30 international unit is further divided based on the meal. Morning, which will be breakfast, lunch and dinner. So what are you going to do? You're going to divide this into 1/3, 1/3, 1/3. So 30 will be 10 international units in the morning, 10 international units in the lunch, and 10 international units in the dinner. I hope you understood this regime. Simple. Whatever dose, 0.3 to 0.4 units per kilogram. Then you will divide 50% for the night, which is the your basal regime, and 50% will be for the bolus. And within this 50%, you're going to divide into 1/3, 1/3, 1/3. And this is how you give the basal-bolus regime. The basal-bolus regime is the best, but the issues come with compliance and the issues come with hypoglycemia. Another regime which we can talk about is the Mixard regime. Mixard regime, which we also, like the 70-30, 30-71, these are the Mixard regime. What do we do in the Mixard regime is that we mix 2 types of insulins. We mix a regular insulin, and then we mix regular is a short acting insulin, and we mix an intermediate one, which is your NPH. The regular insulin is mixed with the ratio of 30 and NPH is 70. That is why whenever you see Mixard 30:70, this is what they're talking about. Now, what we are trying to do in Mixard also we're trying to do the same thing. We're trying to mimic the basal-bolus, where the basal part is controlled by, the basal part will be controlled by the NPH, and the regular one is going to act like the bolus one prior to every meal type of a system. But what is the issues? First of all, let's talk about the advantage. The advantage is, how are you going to give? Mixard regime is just given 2 times. One in the morning and one in the evening. And the logic is same. Before every shot, first you have to make the meal ready. You have to check the blood glucose. Then you take the shot and then you eat. So basically just giving it twice means just 4 pricks per day. So obviously with respect to 7, 4 is better. So compliance is better over here. Now that insulin is not given at a very frequent dose, chances of hypoglycemia is also less. Now what is the disadvantage? The disadvantage will be persistent hyperglycemia, because you notice one thing. See, this blue one is the one which I'm trying to show the insulin effect, because just we're giving twice. On the other hand, we are eating 3 times, right? So you can notice one thing, the glucose control is not proper. Just because of compliance, we're compromising on something. That is why, remember, basal-bolus is the best one. And Mixard is just trying to mimic, but obviously the advantage is compliance. But the another advantage is the risk of hypoglycemia is less. But the disadvantage is you'll have persistent hyperglycemia and there is poor glucose control. And how do you divide it? Similarly, take the same dose 0.3 to 0.5 or 0.4 units per kg. You're going to divide for whatever you got. You're going to give 2/3 in the morning and you will give 1/3 in the evening. For example, if 60 kg was there, okay, if 60 kg was there, what you're going to do is 40 kg you will give in the in the morning and 20 kg you will give in 20 not kg, sorry, this is units, right? 40 units in the morning and 20 units will be given in the evening. So this is how you give the Mixard one. Remember, with respect to Mixard, you can never mix long acting with any other insulin because it is acidic in nature. So remember, whenever you mix, you're mixing a short acting with the intermediate one. And remember which is the best? Basal-bolus regime. Next, a very important line over here. When do you give insulin? Insulin is the drug of choice for type 1 diabetes. Type 1 diabetes, you will not give OHAs, no oral hypoglycemic agents. For type 2 who are refractive to OHAs, diabetic ketoacidosis, hyperosmolar coma, hyperkalemia, and in gestational diabetes, these are the indications for insulin. How do you give insulin? Before, what is the route? I told you the most common route is your subcutaneous route. You will be giving it around the umbilicus, not at the umbilicus. And always once you do it in one site, you have to change the sites, okay? Otherwise the efficacy, if you do it in the same site, because of, the thickness and the wound healing and stuff like that, there will be reduction of efficacy. So always make sure that you're changing the site. It will be in the anterior abdominal wall, 2 centimeters away from the umbilicus, or anterior lateral part of the thigh, or anterior lateral part of the arm. Now, how can you give insulin? There are multiple methods. Methods such as insulin pump. In this over here, this example is an insulin pump, which is a continuous subcutaneous insulin pump. Whenever it detects hyperglycemia, apne aap it will give insulin. You have an insulin pen over here. See, this insulin pen needle, if you see, is very, very fine. Remember, as the gauge increases, the finer the needle be, so that it will be painless and even almost bloodless as well. Inhaled insulin, a freezer, okay? Multi-dose vial insulin with 1 ml syringe, which normally people do. So we're done with insulin. I hope you understood this topic, very important topic. What are the malformations you see in pre-existing diabetes? Very important. Pre-existing diabetes is also known as your overt diabetes. Okay. If you talk about the malformations in especially with respect to pregnancy time, what is the most common type? You will see cardiovascular ones are much more common than the CNS ones. Amongst the cardiovascular one, the most common type is your VSD, that is ventricular septal defect. If they ask you which is the most specific with respect to diabetes, that is going to be TGA, that is transposition of the great arteries. So please make sure you know this question. Options are, which is the most common type of malformation seen in diabetic of a child? It is going to be your heart related, that is cardiovascular. Amongst that, if they'll ask you which is the most common, ventricular septal defect. If they'll ask you which is the most specific, that is your transposition of the great arteries. With respect to the central nervous system, the most common type is going to be spina bifida occulta. What is the meaning of occulta? Hidden. We have talked about all these videos in the pediatrics lecture. Make sure you see that, okay? If they'll ask you with respect to the CNS of a diabetic baby, which is the most specific malformation, most specific is going to be sacral agenesis, where you see it's like a going and the tail is going to be like this because it is known as caudal regression syndrome. It is known as caudal regression syndrome. If they will ask you a very, again, common topic to be asked, which is not a feature of gestational diabetes, they'll ask you congenital malformations, macrosomia, polycythemia, and hypoglycemia. Which will you mark? Answer is congenital malformations, because congenital malformations occur in the first trimester. Gestational diabetes is usually found after 24 weeks. So that is why, remember, congenital malformation can never be seen with respect to gestational diabetes. The patient must have had diabetes before pregnancy itself. That is overt diabetes. So you remember, congenital malformation is only seen in pre-existing diabetes or overt diabetes. Okay, I hope this lecture is very interesting because mostly everything is logic. So as I told you, what is the first management in case of a type 2 diabetes? That is going to be diet control, lifestyle modification. So you have to go under a hypocaloric diet. So hypocaloric diet, which means you have to take food which is of low glycemic index. How I remember it? Remember with mob, where millets, oats, bajra. Remember wheat, the atta wala roti which we eat, it is also very high in sugar, with glucose basically. Corn flakes is also a high glycemic index food. Which fats are completely avoided, which you should avoid? That is going to be trans fats. Trans fats, the ones which you see in oil when you fry, pakode vagara and all. So these should be completely zero in nature, because these are the most dangerous form of dietary fat. Okay, the LDL level with respect to us normally should be less than 100 milligram. But in case of diabetes, we try to reduce it by less than 70, because I remember peripheral arterial disease and all are much more common. Coronary artery disease, these are all macrovascular complications, are much more common in diabetes. So we will try to prevent it by controlling our LDL by less than 70 milligram percent. Okay, so what can you do? You can use oils which are polyunsaturated fatty acids. Okay, you can use oils which are polyunsaturated fatty acids, like sunflower oil, safflower oil. Okay, and you can use statins also. Okay, now if you talk about proteins, with respect to protein, which are the protein you will use? You can eat egg whites. Okay, you can use chicken. Now one thing is there, why do you consider, this was a PYQ, so I just added it up in biochemistry. Why do you think the red wine increases longevity? Because it has a substance which is known as sirtuins. Okay, it has a substance which is sirtuins. Okay, now with diet modification, the patient will also have to work out, that is exercise, but not a very severe workout. Okay, again the chance of hypoglycemia will be more. They have to go for a brisk walk. Okay, it is a light aerobic activity. Every day, at least 5 times in the week, you have to go for 30 minutes walk. So if you see 5 into 30, which means per week 150 minutes of walk should be done, which is brisk walk, a light aerobic activity that is recommended for a diabetic patient. Now, even after this, if you see that the sugar is not getting under control, what are the treatments? One of the best ones is metformin. Metformin is a bigonide. Okay, it is a bigonide. Metformin, the mode of action, very important PYQ. I'm going to talk about this superficially, because I will talk about the drugs used in diabetes in detail in pharmacology. But these are the most important things, so I'm just adding it up over here. So if you talk about the mode of action, remember it is what it does is it inhibits hepatic gluconeogenesis. Another option can be there. It is an AMP kinase inhibitor. Okay, how are the doses? You see it in 500 milligram, 850, 1 gram as well. The maximum per day dose should be 2.5 gram per day. 2.5 gram per day. Now, what is the role of this oral hypoglycemic indexes? It reduces the HbA1c. Now, I told you HbA1c is the best investigation of choice even for long-term control. So what it does is it reduces the HbA1c up to 2% in the next 3 months. Okay, a very important thing you need to know. Okay, now what are the side effects? This is also a very important PYQ which is being asked. First side effect you need to know is obviously nausea. Now another thing what it does is it can cause B12 deficiency. Because it causes B12 deficiency, and especially with respect to diabetic patients who are vegans, mainly you need to know that B12 is a vitamin basically, which is you get it from non-veg meals. So that is why vegans are very prone to this. Now a very important PYQ is that another side effect of metformin is lactic acidosis, and we discussed this in the acid based video, that what type of lactic acidosis is it, type A or type B? Please mention it in the comments which type of lactic acidosis is seen with respect to metformin. Okay, now very important thing is you can't give metformin to everyone. If you check the patient's kidney and the eGFR, the estimated glomerular filtration rate, is less than 30 ml per minute, you will not give metformin. So what will you give? Remember, with respect to LLL, those patients whose eGFR is less than 30, you will give for L linagliptin, L is glipizide, and L will be tolbutamide. So LLL will come here. Okay, so linagliptin, glipizide, and tolbutamide. These three are safe with respect to in case of if patient has issues with the kidney, because these three are metabolized by the liver. They are metabolized by the liver. Linagliptin is a DPP4 inhibitor, which is dipeptidyl peptidase inhibitor. They prevent the degradation of GLP. And IDE, whenever I want to give you a hint, whenever you have drugs with respect to IDE, okay, Eye drugs are those which increase the secretion of insulin. They increase the secretion of insulin. Glipizide is actually a sulfonylurea as well as tolbutamide. Now, metformin, very important, it does not reduce weight, it is a weight neutral drug. Okay, which of the following drug reduces the weight? That is semaglutide. But semaglutide is a very expensive drug. Okay, not everyone can afford it. Next, what about obese patient? What is their management? If you have an obese who has BMI more than 40, you have to think about bariatric surgery. If BMI is more than 30, you can think about semaglutide to reduce the weight. If the BMI is more than 50, this is considered as super obese and they have to go further management as well. Another drug I want to talk about is SGLT2 inhibitors. What does SGLT2 generally do is it causes reabsorption of sugar and salt, water which will be there, right? What this does is it inhibits the sugar to get reabsorbed, so all the sugar will be excreted out. So that is one thing how you can control the sugar. But the issue is that since the sugar is going in the through the urinary tract, you know that this bacteria will eat sugar because they eat sugar, they eat glucose. Chances of urinary tract infection is high because of SGLT2 inhibitor. But a good thing of SGLT2 inhibitor is it helps us and it is cardioprotective as well. So that is why if you have a patient who has, a history of coronary artery disease and all, you can think about giving SGLT2 inhibitor. So remember, drugs like canagliflozin, dapagliflozin or empagliflozin, these are drugs which are example of SGLT2 inhibitors. So the next topic which we will talk about is sulfonylureas. So the sulfonylureas have found to reduce the HbA1c by 1.5%. As I already told you, whenever you have the drugs with ide, these are the ones which increase the secretion of insulin. So they are insulogenic, or they increase by having a sudden burst of insulin. The best part of sulfonylurea is that you just have to take it once a day, so the compliance is good. But since they are insulogenic, and insulin causes hypoglycemia, so the side effect of this drug is also hypoglycemic attacks are common in this. Thiazolidinediones, example is pioglitazone or rosiglitazone. The mode of action is they increase the uptake of GLUT4 receptors which are found in the muscle. So they are good because mostly the majority of our muscle, they have GLUT4 receptors. So they increase the absorption of glucose. The side effect is cardiovascular mortality, very important. Remember, SGLT2 inhibitors help. They are cardioprotective, but thiazolidinediones, these are the ones which are cardiovascular risk. They are increasing the risk of mortality. So that is why if you have a patient who is having diabetes and any arterial disease, peripheral arterial disease, you will not give thiazolidinediones. Okay, they are contraindicated. Another black box warning with respect to thiazolidinediones is that it have been found, or there is some risk associated with urinary bladder cancer. Okay, again, one more advantage with respect to reducing the sugar is the compliance is also fine, because you just have to give it like sulfonylureas just once a day. DPP4, which we already talked about, it inhibits the degradation of GLP. Examples are all the TINs, sitagliptin, linagliptin or saxagliptin. Okay, remember it is produced by the L cells found in the ileum. Incretins. Now as you see, incretins, so like how I remember is DPP4 inhibitor. So inhibitors are the ones which inhibit the degradation of GLP, and incretins sound like increase, so they increase the production of GLP. So you can remember the mode of action this way. Drugs are like exenatide, linaglutide and semaglutide. Again, I told you semaglutide can help in reducing weight, but these are tight drugs, especially exenatide, they have been found to cause increased risk of pancreatitis, specifically hemorrhagic pancreatitis. So you have to take this drug with caution. And again, the advantage of this is you have to take this by injection route, just also once a week. Okay. Last drug which I would like to talk about is alpha glucosidase inhibitors. These are the ones which act within the gastrointestinal tract itself, and they have found to reduce the HbA1c not much, by around 0.25%. The main role of alpha glucosidase inhibitors is that it prevents the sudden increase in spike postprandial, which means is that after every meal which suddenly increases there, it is responsible to control that. So what you have to do is when you eat, now notice one thing, whenever we talk about any drug with OHAs, we're eating it before, but alpha glucosidase is the one which you take along your meal. So while you're eating your meal, that time you have to take. So remember, another PYQ, it is taken with the meal. Example of these drugs are acarbose, voglibos, or miglytol. Now the mode of action, as I told you, it is within the GIT, so it acts by inhibiting the GI absorption of sugar. The side effects are two. You will have diarrhea, especially osmotic diarrhea, so dehydration is common. Along with that, you will have flatulence, Padmarna, okay? And if you have any resistance to the above drugs we have talked about, you have to go with insulin, and we have talked about insulin previously in detail. A topic which I would like to talk about, which is right now very important with respect to PYQs for ophthalmology and medicine, is diabetic retinopathy. Diabetic retinopathy, if they'll ask you, the earliest finding is microaneurysms. And which layer of the retina do you find microaneurysms? Microaneurysms are found in the, very good, inner nuclear layer. In the inner nuclear layer. If you talk about diabetic retinopathy, it can be of two types, non-proliferative and proliferative. Proliferative simply means there is new blood vessels formed, that is neovascularization. If they'll ask you what is the cause of blindness in diabetic retinopathy, specifically non-proliferative, that is going to be macular edema. Macular edema in case of non-proliferative, okay? If you talk about proliferative retinopathy, it is because of neovascularization, new blood vessels begin to form, which is causing retinal detachment, will cause vitreous hemorrhage, eventually will cause blindness. Whenever you have proliferative retinopathy, the management is going to be pan-retinal photocoagulation using anti-YAG laser. Along with this, you can use an anti-VEGF that is known as bevacizumab. Okay? Remember, doctors, that whenever you talk about type 1 diabetes, you like the chances of getting the patient developing diabetic retinopathy or diabetic nephro or neuropathy is within 5 years is much more higher with respect to type 2 diabetes, which they develop slowly by around 15 to 20 years. Okay. A classic history which nowadays comes is a patient has a history of diabetes. Diabetes is an immunocompromised state. HbA1c is 12. Patient has aggressive behavior, urinary incontinence, feverish, and have black nasal discharge. On the examination, you found out in the nasal septum you had black fungal mass. When you did an MRI, you saw that there is a cribriform plate fracture. Involving the spread was into the frontal lobe. Now, because you know in the frontal lobe there are roles with respect to behavior, so that's why as it infected, the patient had aggressive behavior, so behavioral change. The paracentral lobule was also infected, due to which patient also had urinary incontinence. Your diagnosis with respect to black fungus is mucormycosis, and the treatment for mucormycosis is liposomal amphotericin B, and the route also they ask, that is through intravenous. Investigation of choice for such a condition will be nasal endoscopy and biopsy, or MRI paranasal sinus, whichever is there in the option. So this is all which I want to talk about diabetes. We have covered in 2 parts. Okay, a lot of details, around 60-70 mark topics are done. I hope you understood each and everything. If you have any issues, make sure that you can DM me. I'll always be happy to help. And I hope you're understanding this medicine series. And please let me know in the comments below how do you like this series. Okay, thank you, and please make sure you read this, and see you in the next slide. Bye bye.